So just as introduction, my name's Dimple Keane. I'm the Head of Development and Engagement here at NHS Providers. And I've actually worked in the NHS in operational roles for around 10 years. So I feel very connected and close to this topic around improving patient flow through continuous improvement. So great to have you all here today. Now, within my role, I'm responsible for our networks, events, and conferences. And this is one in a series of improvement events that we'll be hosting in the rest of this year. I'm assuming you'll all be familiar with NHS Providers, but just as a quick recap, we're the membership organisation for trusts and foundation trusts across England, helping you to deliver high quality care by enabling you to learn from each other. Now, I don't want to make this political, but we know that some of our friends in politics might use the phrase taking the best of the NHS to the rest of the NHS. And that's essentially what we're trying to do with these kinds of events by bringing people together and hearing some great examples of where colleagues have delivered some really great and innovative work and thinking about how you can take those ideas and apply in your settings. Our improvement programme provides peer learning events and resources designed to help those who are leading improvement. So it's a really great opportunity to come together to explore what that means for you and helping you face your challenges. As I said, today's event is the first in a series of events, and in our post-event email, you'll hear about some of our other events coming up, which you can also join. Okay, I think we're probably nearly there with the number of participants we're expecting. It's great that it's been such a popular event. And I'm really delighted to share that we've got 4 brilliant speakers joining us today representing 3 trusts. And they'll each be speaking about their case study examples of some great work that they have delivered to achieve optimal flow consistently. And we know that services are stretched and really under-resourced, and it's a really challenging ask of you. Just a reminder that this is a safe space for you to surface any issues, reflect on where you are, and also consider what your barriers and enablers could be to achieving optimal patient flow. So we do want to make this an engaging event. And so we do ask you to pop any questions you've got in the chat box, raise your hand if you'd like. And there'll also be a Google Doc going into the chat at some point where you can share some questions if you wanted to leave any comments or questions in an anonymous way, if you would prefer. Our housekeeping, you can see some of the notes up here, but I guess the most important one just to flag is that this session is being recorded so that we can share the webinar with our members so that everybody can get the best value from this. And please do engage as much as you can. Sorry, was there somebody who wanted to come in? Not yet. Okay. Great. So I think we have got a poll going in the chat in just a second. So the poll, it would just be great to hear what you are hoping to get out of today's session. And then thinking about what you believe the biggest barriers to improving flow are. It's multiple choice. You can pick up to 3 choices there. I'll just give you a moment to do that and then we'll move over to presentations. Great answers there. Inefficient systems, can definitely see that. Organizational culture, I think we've got a presentation on that shortly as well. So really important one there to flag. Thank you. Leadership as well, another really important one. Great. Thank you so much for sharing. We'll pause that in just a second, and our first presentation will be with Michael, who's joining us from Royal Berkshire NHS Foundation Trust. He
Thanks,
is
Dimple.
going to tell us a little bit about a quality management system that they've developed over there. So I'll go on pause now and hand over to you, Michael, to tell us all about the great things that you've been working on. Thank you.
Thanks so much. Hopefully everybody can hear me okay. Yeah, hi everybody. I'm Michael, the Associate Director of Improvement and Transformation at Royal Berkshire. Worked in improvement in healthcare for 17 years now, I think. Previous to this, NHSE was the workstream lead on writing the content for NHS Impact, so the 5 components and the self-assessment. So if you liked those, great. If you didn't, I'm really sorry, but I had kind of hands tied behind my back, so had to produce something, and then decided to come back to the acute world because it was nice to get back to the coalface and do things with actual people and patients. So I'm going to talk through today what we have set up at Royal Berkshire and the journey we've been on, and then talk about how we utilize the management system to really kind of focus the whole organization on flow, and how we do some everyday improvement as well to kind of catalyze and move forward that work. I have to awkwardly ask for the next slide every time. Maybe I can do some sort of hand gesture. We can move it on from there. So our journey so far, we sort of say we started improving together, as we call it, which is our improvement approach, in 2022. But actually, it probably started in 2017 when the organization did a lot of work around its values, its leadership behavior framework, its engagement with staff. So we have a really good culture of people feeling valued. We regularly score in the top 1, 2, or 3 trusts in the country and the staff survey for the place to work, on the questions around I feel like I can make improvements to my job. All of that good stuff is kind of was there before we started this, and I genuinely think that's probably why it's progressed so quickly in such a short period of time. As you can see from the roadmap, I'm not going to talk through it, but essentially we did a strategy deployment and kind of implemented a management system, which I'll talk through. And since then, we've been rolling out across the organization, trying to increase capability and develop those kind of contributing driver lanes towards that management system. And then last year, we implemented rapid process improvement workshops, again, which I'll touch on towards the end. I'm aware I've got 12 minutes, and then Dimple's going to cut me off from the call. So I'll go as quickly as I can. Next slide would be great, please. So yeah, as I mentioned, our 3 elements for our improvement methodology. Side note, if I could rewrite the 5 components of NHS Impact, I think I'd probably write them as these 3, but can't do that, so we'll stick with the 5. These 3 is around what I just talked about, so the cultural values and behaviours. So how do you embed a leadership behaviour framework through appraisal systems? How do you have mass engagement with all staff every few years to make sure you're heading in the same direction? All really important. Second element being an improvement management system. I could get told off on this call because there's a lot of experts, but I genuinely don't think that a management system is fully understood by many people across the NHS. I think it's understood academically, and the idea of one is understood well, but tangibly putting it into an organization is quite hard to fathom unless you've seen it. And I know my viewpoint changed massively when I started working here, and I saw how it was done, and we've grown it over the last year. And then finally, everyday improvement by everyone. So how do you make improvement part of everybody's lives and give them the tools they need to be able to do that? So I think the next slide goes on to talk about management system. Yeah, so basically we have, as all organizations will have, we have our vision. So working together, we have our 5 strategic objectives. I haven't included it on here, but beneath each of those is sort of quite a clear set of strategic metrics that we're looking to measure. But then I think the first stage of the management system is we then have 3 what we call breakthrough priorities. So the boxes at the bottom in red are the things that we are focused on as an organization for the next 12 to 18 months. They will not change, and they are the focal point of every bit of work that every member of staff is trying to do. So instead of having 6, 12 20 different priorities that we're trying to achieve. We really hone down and focus, and they're driven from the top of the organization all the way down. So if we take, for example, average length of stay, because we're talking about flow today, so that's our flow breakthrough priority, and we go on to the next slide, you'll see kind of how that cascades through the organization. So at a top level, our breakthrough priority is improved flow, average length of stay. At a care group level or a division level, depending on how you organize your organization. So here we have our network care group, and their driver metric towards that is length of stay for non-elective admissions. They know their current performance, they know their target, they're working on trying to reduce it. And they then communicate downwards and upwards from their directorate. So each directorate in that care group will then come with a set of driver metrics that says, the example here is reducing length of stay on elderly care wards. So again, they know their performance, they know their target, and then you get down to the frontline team of an elderly care ward, and they're trying to increase the accuracy of target date of discharge, because we know that has an impact on how long people stay in elderly care wards, which in turn has an impact of the length of stay of elective admissions, which in turn will impact improving flow across the organization. So you have this full up and down golden thread through the organization, where ideally, no matter who you talk to in every team, it's the same for us as an improvement and transformation function. We have our weekly huddles, we have driver lanes, we understand how those driver lanes are contributing towards those 3 breakthrough priorities, and everybody aligns their work around what we're trying to achieve as an organization. So less giving you a case study about how we have improved flow and more giving you the framework we put in place to enable everybody to kind of work towards flow. I think it would be interesting. Can I ask people to put stuff in the chat? Could you put in the chat if you've heard the awful anecdote about the NASA janitor? That would be really helpful. I think everybody on the call will have heard it, but the awful anecdote of being, went to NASA, asked the janitor what they did. Yeah, we're getting loads of yeses. Perfect. I truly believe that that's been used wrong in the NHS for the last decade, because that was always told to me as, oh, that's because they're all doing improvement and he knows that he needs to improve and what he improves really contributes. It's not, I don't think. I think he knows what his job is, and he can see the golden thread at every layer of the organization, right to the breakthrough priority of putting a man on the moon being the end goal. So personally, that's been like a revelation for me over the last few months. So yeah, correct me if I'm wrong in the chat. Very happy to be told I'm completely off the mark. Next slide, please. So to back up this management system, and I've just come from board where we're actually doing this with our non-execs today as well, we have every week the execs huddle for half an hour. So they get together and they talk through every week one of the breakthrough priority lanes. So it could be flow, could be outpatients, could be financial turnaround. And they go through this standard work. So they firstly talk through the go and sees that happened from last week. So every week they get assigned a set of go and sees from the SRO for that breakthrough. And they say, we're doing really well here. Could you go and see how well they're doing, give them some celebration, understand their process a bit better? Or we're struggling a bit here. Could you go and see what the problem is and frame it for them in a different way and offer them some support? So we really have this sort of really good rhythm of the execs huddle every week. They do go sees every week, and then they feed back every week. And that enables us to keep the management system kind of ticking over from the top down. And then I think if I've got time, I'm just going to talk about rapid process improvement workshops on the next slide. So again, this year we've introduced these, and a lot of people in the chat will have heard of them, but this is essentially a focused event looking inch wide, mile deep at a specific process, and it's looking at not an entire pathway. There's no way you can do that. It's designed to be 8 weeks of planning with us as a team and the team that are doing the work. That's sort of touch points during those 8 weeks, us going to do observations, understanding the process. It's then a whole 5 days of taking a good chunk of the team out of their work and putting them into a different environment where they receive lean training. They understand their current state in far more depth than they did before, and they design a future state that they want to test and implement. And then they spend the week making the changes. So we have estates on call, we have IT on call, we have all the different departments that need to support them ready and waiting. And we rapidly make changes through the week as quickly as possible. We've done this in outpatient gynecology, we've done it on the TTO process, and we just a couple of weeks ago ran one on day surgery in one of our spoke sites. Our plan is to do 6 of these next year and then to continue to grow this approach. But I think the next slide shows what we did with TTO. So the problem was we were having delays with TTOs getting delivered to the ward through pharmacy. And that was because of both pharmacy and portering. So we pulled those 2 teams that usually work quite siloed together, and we put them in a room for 5 days, and we get them to understand the process. Next slide, sorry. Their current state was messy. There was a lot of people saying, I can't believe all of that has to happen before we get a TTO to a patient. Lots of improvement bursts, lots of different things that can be done. They designed a future state, which is on the next slide. So they looked to kind of really cut the process down. It became very simple to them that this is what we need to try and get towards. And then they sort of used those 2 to generate, I think they came up with over 70 different ideas of how they can do it. My team are a big fan of Ted Lasso, so they produced an awful looking box with a face and a tongue on it. And we generated action plans based on those ideas, and then we implemented them through the week, and they're still working on them. We have 30, 60, 90-day check-ins, but I think if you go to the next page, you start to see that we went from within a week, the baseline being kind of it taking 2 hours 32 to get a TTO out to the ward to 2 hours 19. We had kind of TTO booked incomplete. We didn't see an increase. So again, we're not particularly afraid of failure. We quite embrace it and we quite push for it, because at 30, 60, 90 days, we need to think about how we can alter that. But again, waiting to check in reduced, handover time reduced, the portering changed their rotas, so they actually got an extra hour of work out of the day. So we did a lot in that week, and we continue to do these events, as well as running a large-scale improvement program around flow, which is obviously one of our breakthrough priorities. I'm pointing to a wall and you can't see, but on the back of that wall there is our breakthrough priority lanes. So on there will be flow, there'll be the data from this month, there'll be the actions that have been taken at a care group level, and that'll be talked through this afternoon with board. I don't know how close I am to my 12 minutes. I'm really sorry, Dimple. I really tried to get all of that in as quickly as I could. I hope it was clear. Oh, yes, there's a picture of pharmacy and portering high-fiving, which they chose to do. This wasn't dictated they had to do. And they will not be happy for me showing this on a national call. But they're not here, so it's fine.
Thank you so much, Michael. I love the mandatory high five. I think that is absolutely essential.
I must stress it was not mandatory. They wanted to.
You are bang on time, and I think there's just such rich information in there. I could probably spend about another half an hour asking you more questions. So I'll just invite the group to Alexina or Katie. I don't know if you can just pop the Google Doc back into the chat so people can access. If you do have more questions, please do add it in there. I guess a really interesting observation / question I've got, Michael, is sometimes with the example that you just gave with the porters and the pharmacy teams, sometimes you can see great improvement straight away because there's been momentum. There's been real focus and people feel motivated, and they'll actually try that little bit harder, won't they? Because they're excited. What's been your experience about that being sustained over a longer period of time? Or not necessarily just that example, but in other examples of work that you've done?
So I think the focus of it being a breakthrough priority for us is the biggest contributor to that. So we focus on, through that work stream, target date of discharge, utilization of the discharge lounge, and effective and use and productive board rounds. They're the 3 things that program focuses on, and they're what drive us forward in that area. And I think we've had commitment to that for nearly 18 months now, and we've not wavered as a senior team. They've not wavered as how we send the messages out. We've not wavered, and the chart is getting better every single month because of that. And I think it would have been very easy after 6 months of not very little growth to think, well, we're not in the right area. Even though the data is telling us we're in the right area, it's not working. So we'll jump somewhere else. We'll do something new. But I think, again, running it through the kind of management system approach of having that clarity from top to bottom of everybody driving in the same direction has really given us the staying power to be like trust in the process and trust that what we are looking at is going to have an impact on that final goal. When it comes to the kind of momentum of a rapid process improvement workshop, I think it comes back to the cultural point that I made at the start. I've worked a lot of places and I've seen a lot of organizations. I've not worked anywhere like Royal Berkshire in that it is genuinely different. Like, I can walk into ED and say, and I have walked into ED and said, do you fancy doing a stand-up huddle at noon every day around a whiteboard, looking at your production for the day and how you can get better in the afternoon? And they've gone, yeah, great. When can we start? I would get like literally beaten out of an ED in any other hospital, I think, for suggesting that. And it would take me a long time to build the relationships, to build the right sort of atmosphere to be doing that. So I'm not suggesting we're special. I know there are amazing sites across the NHS. It feels a bit different here. So the RPIW, instead of seeing teams stop working with us, we've actually seen teams flourish beyond what we expected. So the first one we did was in gynae outpatients, and instead of trying to get to their future state, they're thinking about putting in a one-stop shop. They're developing their process beyond where we even thought capable, because they are using the tools and they're seeing how they can develop it. So without the cultural foundation, it's very difficult to have a go at this stuff. Again, I thought I'd have a battle trying to sell a 5-day event. Again, other places I've worked, they've said, can we do it in 3? Do you think you can do it in 1? No pushback at all here, just straight in with 5, wanted to give it a go, curious to see how it worked. So yeah, I can't take any credit for any of that. It's all pre-me.
So much for that, Michael. It's great that you touched on that point, and you once you get a moment, do please have a look at the Google Doc, because actually there are quite a few questions in there and lots of inspirational bits of feedback. And one of the questions actually was around that 5-day commitment. So really great that you've touched on that. And I totally agree. It does come back to culture, doesn't it? So thank you so much for your really great presentation. Definitely lots of interest in further discussions. So thank you so much. We'll move now to Paul, who's joining us from University Hospitals Leicester. Paul, we'll hand over to you to tell us about some great work that you're doing over there. Thank you.
Really good. Thank you very much. Morning, everybody, and thank you to Michael as well. So my name's Paul Brooks-Baker. I'm head of continuous improvement in UHL in Leicestershire. I've been in UHL for probably around about 3.5 years now, and that's my only experience of the NHS. Prior to that, my past life was working 20 years for Toyota as senior quality manager, and 30 years in automotive in total. So it's been an interesting switch to kind of see how things are in the NHS and healthcare. So what I'm going to do is briefly take you through our activities really over the last 12 to 18 months in terms of cultural development. So it was nice to see kind of the learnings from NHS Impact through the Virginia Mason collaboration. We've used that to kind of inform our continuous improvement strategy going forward. And obviously, from my point of view, a lot of this is very, very familiar in terms of its ultimate source material, which VMI takes its learnings from. Next slide, please. So in terms of where we were, we did the cultural maturity self-assessment when that came out, and that kind of highlighted that we were very much at an early stage, even though there's been past initiatives to try to foster and develop improvement culture and establish that. Things haven't uniformly progressed. There's been pockets of progress in certain areas, but not where we would ideally need to be. So in the last 12 months, we've developed our kind of top level vision, and we've signposted that continuous improvement is a key enabler as part of realizing those goals and so on. And so what we've recently put together is our strategy for the next 3 years. Obviously, the journey is much longer than that in terms of how we can start to move forward and build that continuous improvement behavior, culture, and thinking way. Next slide, please. So one of the things that we've put in the strategy for the next 3 years is as well as general overall directions, a little bit like what Michael was saying in terms of what I would call Hoshin Kanri in terms of the strategic cascade. We've also tried to be specific in terms of some of the key steps over the next 3 years that we want to develop. And because this is developing culture right across the trust and 18,000 people across, well, three sort of primary sites, it's not just purely about QI in inverted commas. These are inherent practices and processes which touch upon that strategic goals cascade that Michael explained very well, but also things like progression framework, appraisal system, and many other elements as well, which are far beyond just my initial sort of remit. So what we've tried to do is be explicit in terms of starting to build these elements in recognition, and we're not going to do everything all at once. Next slide, please. One of the things that I keep coming across is, generally speaking, a kind of perhaps a misunderstanding, for want of a better phrase, between what is QI and what is generally more of an improvement culture. Some people who I speak to, basically, if you talk about continuous improvement, they just think, oh, it's the model for improvement. And clearly that's obviously part of it, but it's nowhere near describes what it is we're looking to embed and adopt. So I find it sometimes useful to kind of paint a picture of what is improvement culture and what does that tacitly mean, rather than kind of more the conceptual elements, and also what is QI methodology, what is the purpose of that, and where and how does it fit. So brief explanation that I've got in front of you there is I find is quite helpful when kind of coaching people. Next slide, please. So I'm going to touch a little bit on some of the continuous improvement culture elements that we're focusing on. And whereas, again, Michael touched upon really well the kind of goals cascade, and there's obviously huge amounts of elements around engagement of people and respect for people and so on. The bit I'm going to focus on is what I would call process management. And that is, how can we engage and empower people, no matter what their job role, to improve their process day by day and little by little and so on, as part of their routine daily job. And one of the key approaches we take on that is, and it's an old phrase, in terms of helping them and coaching them in terms of learning to see, view things as a process. What does a process need to run smoothly and continuously? And then also to think about what frustrates you within your process, what are abnormalities, and also to identify process waste. And so what this does is, by seeing that, it enables them to start to take action in that sort of routine daily job role. Next slide, please. And we talk about, well, how do we start to build those behaviors? Because effectively, as we would say in Toyota, all the tools and everything that we use are what's required at that point in time in order to generate the right behaviors. And so Michael touched upon what we would call process huddle boards. So visualization is absolutely key in terms of, driving the bus and not being on the back seat of the bus when it comes to managing and improving your process. Other straightforward quick wins are things like 5S to start to develop that improvement behavior, and also really a deeper understanding around the purpose and the benefits of standardized work. So all of these things, they all interlink and they all matter, and they're all absolutely key in terms of what I will call shop floor process management. And it's absolutely vital to embed that to develop sustainable continuous improvement culture. And the senior executive team and the leadership team as a whole play an absolute vital role in that, because if they're not modeling those behaviors and asking those right questions and having those expectations of how shop floors, for example, should be managed, then behaviors will slip. I'm afraid it is a situation of the constant gardener in terms of embedding and maintaining behaviors. Next slide, please. So on the flip side of that, in terms of QI methodology, so we've developed what we call MyQI within UHL, and that doesn't kind of hang itself just off a single model for improvement, for example. Model for improvement and others like it, they're all fundamentally based on lean problem solving and process improvement methodology. And what we've developed is a framework around more geared to individuals' job roles. So, for example, a frontline nurse versus somebody who is perhaps more full-time as an improvement practitioner. So we've got a scalable framework, but also recognize the fact that we can train, hundreds of people on the front line in terms of doing improvement work. But if we don't develop our leadership team and local leadership teams, we're putting people back in the system and they might not be given the opportunity to actually apply what they've learned. So to develop our local leadership is absolutely vital so that they create the right environment that empower people to make those improvements and to have that psychological safety around it. Another key one as well in terms of our training approach, and this is kind of ingrained within my previous life in Toyota, is that it's not just classroom. We do some classroom teaching initially for our delegates, but then everything else is based on coaching for them to deliver an improvement project and develop the skills and deeper understanding around how to go about improving a process or resolving problems. Next slide, please. One of the things that we've identified, so I'm responsible not just for the QI team, but also the clinical audit team. So within our trust, the clinical audit team have quite a wide network established already, and obviously lots of audits happen. But by strongly linking by organizational structure, the clinical audit team and the QI team, it allows us to kind of graft onto that existing network and level up the improvements that are done through it. We've had a tendency, and we still do it, we're still massively on that journey whereby we do an audit, we're great at measuring stuff, and if there's a gap, perhaps that will then trigger some training, some awareness, maybe a poster or something like that. But when it comes to robust and sustained countermeasure action based on root cause understanding, historically that's been quite weak. But by embedding our QI methodology with clinical audit, it puts us in a position to level that up across the trust. And what we've done is built our own SharePoint site where we have all the tools in there. We have our workbooks, which include our A3 templates, control charts, run charts, fishbone diagrams, process mapping tools, and all the rest of it, all in one place. And we can see at a glance where we are as a trust, and anybody can go into that and look at projects and do the usual searching and so on around things that they may be interested in. So it was quite a bonus to be able to use the clinical audit network in that way. Next slide, please. And building capability, linking in with clinical audit as well. We've developed quite a big program now, what we call AQUIP, and we do quarterly showcase awards, which go on to an annual award, and we try and really focus on that to help build momentum, that recognition for those people who've completed a project within their own process, within their own daily jobs, and to give them recognition for it. Next slide, please. But we can't just rely on that. So what we have also done and will still progress to do is build that QI methodology in the continuous improvement thinking way within hard programs and systems already in the trust. So these include award accreditation, strongly linking the QI thinking way within PSERF to supplement SEEPs and so on. But also what we've been able to do, because we primarily use the 8-step lean problem-solving approach, we've grafted on co-production, co-design with lived experience patients, and also embedded it within our trainee doctor programs as well. Next slide, please. So in terms of delivery, so as mentioned, we use an A3 approach and follow those 8 steps as detailed on those. We've got many breakthrough project examples, but the key one that we're going to briefly touch upon is the implementation of frailty SDEC. But you can see the process there at on the funnel diagram in terms of typically what we go through, linking that with an MDT approach. Next slide, please. So frailty SDEC is nothing new. So this was a little bit of a different kind of QI project insofar as it was, to some extent, initially a copy-paste, a Yoka 10, as I will call it. But nevertheless, the process of understanding where we currently are, so our current state is outlined here, and then pulling everybody together, doing that Genchi Genbutsu, speaking with who are currently working within that process and pathway, to actually start to then build the future state. Next slide, please. which looks a little bit more complicated, but this includes some significant change points with Frailty SDEC. So the blue in the kind of off center is kind of a change points around the original ED process that we've made. But in addition to that, what we have done is created a separate physical space where suitable frailty patients can be moved to start reducing the length of stay within ED. But then before that blue section, what we've also started this month is direct GP referrals from primary care. So it completely bypasses ED and goes straight to Frailty SDEC. So the benefit in terms of getting everybody together to build the future state is you can do some advanced problem solving in terms of, well, how will this work? How do we want it to work? And what do we need to make it work by going element by element and step by step in advance? Next slide, please. And then there's obviously setting that process up and launching that, all the comms around it, developing the SOPs and so on. Next slide, please. And the other thing that we've developed as well is a live dashboard. So what we can see at a glance in a much simplified way is how is that process running and where are there further opportunities to further improve it, enhance it. And so what we've done with that is develop a once a day improvement meeting where we can raise up any kind of issues that are causing problems for that rapid cycle improvement and development. Next slide, please. And then finally, what we can do is analyze the effectiveness of that, look at the before and after versus baseline. Is it statistically significant in terms of the results that we're achieving, which we can demonstrate through t-tests or p-values and so on. And that then helps to make sure that the trial that we're doing for 3 months at the minute converts into a permanent process, because effectively it pays for itself. It's a no-brainer, and the benefits are statistically proven. That's it. Thank you very much for listening. Any questions?
That was so great. Thank you so much, Paul. Again, I think just looking in the Google Doc, which you'll hopefully get a chance to in just a moment, there's lots of questions, lots of interesting reflections, and just to confirm, we will be sending the slides out as well for everybody to kind of digest all of the materials. Paul, I think there was just such great depth in your presentation, and I particularly resonated with that local leadership part. I think we can have all of the improvement experts in the world, you know, talking about QI and continuous improvement and the need, but I think you need to get to the shop floor, don't you, and having those people who were delivering the work, taking ownership for that. What has been the feedback from your staff members in being involved in such a vast range of really exciting work on top of their day jobs?
To be honest, you know, certainly from the delegates we train and coach through projects and stuff like that, they're really motivated. They're really, I'd almost say excited. Well, they are excited to kind of do it. That doesn't necessarily mean to say they don't get some moments along the way where they perhaps want to cry when they realize, you know, some of the things that needs to happen as part of that process. One of the, I mean, I could talk for, you know, another couple of hours in terms of the differences I've come across in terms of my previous life to what I've encountered. But one of my observations amongst many is that there seems to be a tendency within UHL, as I say, I'm using that as my kind of benchmark for the NHS, where in terms of whether it's model for improvement or 8-step problem solving approach, instead of working through with data and being data led in terms of what's my gap to target or standard that I'm trying to close and achieve, what creates that gap, and doing the deep dive and working through that, it's like, well, this is my problem, here's my solution. We jump straight to it without truly understanding what the causes are. And it could be, oh, I think this is a great idea, I'm going to do that. And it could be a nice little Kaizen, but it's not necessarily going to resolve that problem. And what that then creates is what I've termed as layering. We'll layer more and more and more stuff to try and resolve something, but invariably it doesn't resolve it. And actually what it does is probably create more work without actually resolving the underlying issue. And so to try and prevent that by gathering the data that's required and going through that process, sometimes initially people think, oh my goodness, this is a bit more involved than what I thought. that then what it does is expose the fact that often the data that we really need to understand the process isn't available. We have to do more to try and obtain that. But equally, we can't just rely on data itself. As my old Japanese coordinator used to coach me in, to make the best decisions, you need data, plus you need that tacit knowledge and understanding through go and see and understanding the process. That way you gain wisdom to then make the best decisions. And I don't see that happening anywhere near as much as it should be.
Thanks so much, Paul. Just really fascinating bit. And I think it was Albert Einstein who said if he had an hour to solve a problem, he'd spend 55 minutes thinking about the problem and then 5 minutes on the solution, which exactly is what you're describing there. Spend some time doing that analysis. Purely in the interest of time, I'm just going to direct questions to the Google Doc for everybody. Alexina or Katie, if you wouldn't mind just popping that in the chat again so people can access. And Paul, Michael, when you get a moment, you can have a look and respond to various things on there. And we'll circulate that to the group as well. But without further ado, we'll move on to our last presentation for the morning with Alison and Tara joining us from Leeds. We'll hand over to you. Thank you so much.
Thank you. Hi, everybody. I hope you can hear me. My name is Tara. I'm a service manager for urgent care working within Leeds Teaching Hospital Trust. We're just here today just to talk to you about a couple of things that we're doing within the trust and the improvement that that's brought. So what I'm here to talk to you about today is the primary care access line. Next slide, please. So what is the primary care access line? So the primary care access line is a telephone service that takes acute referrals from primary care providers in Leeds and directs them for the most suitable treatment in the most suitable place in the right time. So when we started the service in 2003, we started on about 10 calls a day with 3 clinical access pathways. I think it was DVT, headache and something else, and we had 1 band 6 registered nurse. So fast forward to the end of the last financial year, and we've been able to scale that up to 400 calls a day. That's around 85,000 calls a year. We have over 50 clinical access pathways. We have a much larger team consisting of clinical and non-clinical roles, and we're open 365 days a year. So who's referring to the PCAL service? So next slide, please. So we take referrals from any primary care provider within Leeds. So GPs are our highest referral number, but we also take referrals from paramedics on the roadside, advanced practitioners, community midwives, optometrists. Anybody who sees patient within the primary care setting can refer into the PCAL service. So just to give you a bit of an idea of the patient journey before PCAL, so very standardised. So the patient went to see their GP, they had an appointment at the GP surgery. The patient then had their consultation, and the GP thinks that the patient, and I have put seen within ED, but actually the GP thinks that a patient needs to be seen within the hospital. So what they do is, historically, they write the patient a letter and send the patient off to ED. So next slide, please. The patient arrives in ED, they have to queue up, they book in, they get seen by a streaming nurse, they then get put into ED, who will then do another assessment. They wait to then be seen by a doctor, who will then refer them on to the appropriate area. So what we can see in this process is there's a lot of non-value added waste, and really PCAL is about removing that waste and streamlining the patient journey. So if we now go on to the next slide, which is the patient journey with PCAL, and I've just skipped through some of those, but as you can see, it's quite a long pathway, an historical pathway. So next slide, please. Sorry, next slide. Next slide. So the patient journey with PCAL, so the exact same pathway. So the patient goes to see their GP, they have that consultation, and the GP thinks they need to be seen within the hospital. So the GP phones PCAL. Next slide, please. So the GP has a consultation with a specialist or a PCAL nurse, and an outcome is agreed. So what PCAL would do is either give advice, so they can just give specialist advice. So we do have access to a number of specialities throughout the trust if that advice is needed. We can access same-day speciality assessment units, so that's our SDEC units and our assessment areas, and we can arrange an arrival time, so we know when the service might be less busy. So again, great for the patient, great for our services, because what we can do is set out the arrival times of patients, so that also makes the work within the assessment units more regular. We can access outpatient appointments, so we can actually access same day or next day outpatient appointments, which patients really like because it means they don't have to come and sit and wait for a service. They have an arrival time, they get seen for an outpatient, and then they get discharged home. We can refer them back into community services, so that's at practices near to their house with specialist services. Or if it's clinically appropriate to do so, we can arrange for admission direct for awards, and if it's suitable, patients can wait at home for a bed to become available. So again, it's really about ensuring that patients can go to the right place at the right time. So next slide, please. So just a little bit about our referral numbers going back to 2018, 2019, and as you can see, we're continuously increasing the number of referrals whilst reducing the time to answer. And the way we're doing that really is our continuous improvement. So every single day we are finding ways to improve the service and identifying wastes in the system. So if what you can see here is in the year 22-23, we've really had a big step up in the service. So what we did then is really map out all our pathways. We assigned nursing leads, so within the PCAL team, so really the people doing the job on a day-to-day basis, they're the ones leading and driving these pathways and liaising with our speciality teams. So what we found works really well in the service is having that dedicated person to go to and speak to and to take feedback from. And we've also really upped our engagement with our stakeholders. So we really did a dedicated piece of work with the ICB and the GP Confederation in Leeds, really trying to understand what the issues are and what the blockages are for people to ring the PCAL service. The biggest feedback we got from this service was that the longer you take to answer, the more we're not going to ring. So one of our focus really was on reducing that time to answer. So we implemented some admin staff to take the calls. We really focused on having our nursing colleagues really only doing the nursing conversations and undertaking those nursing tasks, really streamlining the process. And I think it is about everyday monitoring of performance, everyday monitoring of feedback, and seeing really where we can continue to improve. We quite often take feedback from our referrers and take that to specialities and say, well, actually, we could improve this pathway by maybe offering outpatients appointments. So, yeah, that's really helpful. I've just seen a little question pop up about ED attendances, so that is on the next slide. So what you can really see is in the last few years that this piece of work has dropped our ED attendances. So we have gone from 23% of calls resulting in an ED attendance to what it is today, which is about 9%. And how we've done that is by expanding our criteria into different services. So what you can also see is actually we send around 55% of patients to assessment areas and into our SDEC units throughout the trust. And as a trust, we have really, from a trust perspective, we've really been supported that all acute referrals come through PCAL, because again, I think previously when you've got lots of different pathways directly into different areas, if you're a paramedic with a patient, it's really difficult, isn't it, to say, oh, I'm not really sure which place I should be accessing. So the premise of PCAL is if you're not sure, it doesn't matter, ring PCAL and we will have that discussion with you. So as a result, we have seen a reduction in the numbers to ED. And so as you can see, again, sorry, just to say that year on year, our numbers are improving, and our goal for next year is to decrease that number to ED even further. The only patients we should be sending to ED is those that are clinically needed to go to there. Next slide, please. So again, I have mentioned that continuous improvement, but what we do is we meet monthly with all our specialities. We have really good working relationships with all our specialities, and it really is a two-way street. So how we can help them to improve patient care and how they can help us to offer more to our referrers. We meet monthly with our biggest stakeholders, so that is the Yorkshire Ambulance Service and the GPs. And again, that's really important because we really want to hear their feedback, but also we really need to get our message out there. And also it's about promoting the improvements that we have done, because what we found is, again, I mentioned it earlier, but if someone has a bad experience, they stop using the service. So it's just about really making sure that we're letting our stakeholders know that we're continuing taking the feedback on board and we're continuing to make changes. And we're also just looking at our internal processes. So just very quickly, so we did have a lot of issues raised from GP surgeries that the time to answer was increasing, and that was because we had our nursing staff answering calls. So by moving that to a different to our admin member of staff, we were able to free up our nursing point of time to give us more capacity within the service. So I think that is the end of my, oh, sorry. So yeah, so our message just for everyone is really think hospital and think PCAL, and just by using that message, we have managed to improve the service. Thank you.
Thanks so much, Tara, and we're going to move on to Alison, who's also from Leeds but presenting a slightly different topic. So we'll just ensure that questions for Tara do go into the Word doc. I mean, there's so much that we could go to there, but we definitely need to hear from Alison. So over to you, Alison.
Thanks, Dimple. Hi, everyone. My name's Alison Beckett. I'm the Head of Nursing for the Operations Centre at Leeds Teaching Hospitals. And I'm just going to talk, I'll try and keep to time because I'm aware of we're nearing the end of the session, about a whole trust Leeds improvement project we did here at Leeds, which we called Making Every Day Count. So the aim of our initiative was to use, we call it in Leeds, our Leeds improvement method, but it's based again on the Virginia Mason principles of how we can empower our staff to improve ward efficiency and therefore reduce the patient's length of stay. So we did this through a three-pronged approach, starting back in July 2024, where we did a rapid improvement week, including 3 different wards in 3 of our clinical service units. So on a smaller scale, looking at how we can ensure that we are adding value to every patient every day. And we scaled that up to a whole trust improvement project in October 2024. And we did initially some weekly exec reports out, and then we've moved to a 30-day, a 60-day and a 90-day report out. So next slide, please. So why was this undertaken? We do know, and everybody's seen the stats around how we're causing harm by people waiting, particularly in our ED departments. And one of the aims was to reduce those harms to patients from those avoidable delays. We also needed to look at what our standard work and role clarity is. And we know that if we get that right, we will have then effective teams, both from a leadership level and at ward level. we needed to look at reducing and a collective strategy of how we were going to reduce those delays. Some of the early work we did looked at the fact that we accept delays, so we'll get to blood tests, we have you know, things done to patients, and we know it takes 48 hours, etc., to actually get results. And why is that? And can we do better? And then we did look at some specific work to ensure timely completion of our EDANs. I noticed somebody earlier called them TTOs, but basically medicines to go home. We all obviously are having that same challenge around that. Next slide, please. So we needed to look at how we measured our impact. And these, I won't go through all of these, but these are the different ways that we said we were going to make a difference, and we were going to see if it was a success. You'll see some of those are very data driven when you're looking at sort of length of stay, completion of EDDs, etc. But some of them were around morale, quality, and how it feels to be a patient in our organisation. So we hopefully have got a good range there. Next slide, please. One thing that we've learned through doing many of our different improvement programs is to try and set expectations for the staff that we want to be involved, particularly when it's on such a large scale as we did it. So we did socialise what's called a bundle, which I'll go through in a second, with our clinical colleagues. We also asked people to understand and document where their clinical team's starting points were. So for some of this work, some people were way ahead, and we didn't want to take people back to redo work that they'd already done over maybe the last 6 to 12 months, but acknowledging the fact that for some people this was completely new. So actually understand where your starting point was and see how you can move on from there. So we looked at how we could support clinical teams to build on what was their existing processes, and how, like I say, that golden thread of how we can add value-added days for patients in our care. Again, to support clinical colleagues to understand what their opportunities were, what were the tests, the interventions, what measures we could do, and that comes into the bundle. But the main thing around the culture was to be curious and explore how we can remove those barriers to improvement. What are those things we've accepted over many years and for many reasons, and what could we just do, even one little thing differently that might make a difference to a patient? Next slide, please. So I've mentioned the bundle. What we did was we pulled together, and this was co-produced across the whole organisation, a lot of it from the RPIW. We looked at a bundle that we could give people. That's what they asked us for. What tools can we have to do this? So we created action cards which outlined roles and responsibilities. We did standard work for what makes a good MDT, standard ward processes for their huddles and their MDTs, for all patients to have an accurate expected date of discharge on PPM. That's still work in progress, but we are working on that. To have an MDT production board or live action list, something that documents centrally what's happening each day for each patient in each clinical area. And also to empower patients to understand what their journey is and where they fit into it. So next slide, please. This is just an example of an action card. It was a real balance between keeping it simple, but giving enough detail that people knew what to do. What has happened with these, and I'll go on a little bit more to talk about in a minute, is that we started with sort of a core of about 4 of these. And then as people saw the value, people were saying, oh, it'd be great if our ward clerk could have one. It'd be great if our therapist could have one. And then that's come out of the report out, so, which is really good and positive. Next slide, please. So for the patient involvement, we concentrated on 4 key questions, which people will have seen before, a part of the Health Watch, to help people understand what's happening to them. So we use these 4 questions. A lot of this is obviously a poster that we have used and has gone up in many areas, about what do I know about why I'm here, what's wrong with me, what's going to happen today, what do I need to do to achieve to get home, and if my recovery is ideal, there's no unnecessary waitings, when should I expect to go home? We were quite surprised when we did some of the initial questions around the fact that people didn't know and relatives didn't know what the next steps were. So that was a key driver behind this. So after we did the whole improvement programme back in October, what's going well? So what we have managed to achieve is good knowledge and awareness of the Making Every Day Count on all wards, which is no mean feat when we've got over 90 clinical areas. We've got good high staff engagement and motivation, and we have rolled this out across all wards. Like I've mentioned, the action cards continue to be developed, and that is really driven by the people on the shop floor saying this is a really good prompt, it's really good standardization, can we have them for this? And it's then that group of staff that have helped to develop it. One of our key measures is our discharge lounge usage. And again, people have talked about that earlier on. It seems to be quite a challenge for all of us, but this has put a real focus on how we can use them. What processes do we need within the discharge lounge to make it as easy as possible to use it? Our collaboration with our therapy colleagues, who are so critical, particularly for our long stayer patients, to be able to get those home or to the next steps. And identify in our golden patients. So these are patients that are fit for discharge before 10 a.m. in the morning. That's something that's really improved and has helped them with our discharge lounge usage, because the patients are ready to go, can often move to the discharge lounge, and then that releases that bed back to be able to improve that patient flow. The other key element that has really, really made a difference is our 4 p.m. huddle. And that's something that came out of the RPIW. That often on MDTs, things are worked through. We know what needs to happen, but it's actually the next day before anybody goes back and sees what the outcome of that is. So the big step we put in was a 4 p.m. huddle where people get back together and say, okay, we've got the result for this. What do we need for the next step? And actually that roundup of what's happened to those patients that day and what can we do? So some of that has then unintended consequences. Some of that work is then done later in the day. So we've got patients going home later in the day. There's some pressure on our pharmacy colleagues, on our therapy colleagues, but it's a great position to be in because it's the day before it would have been. Next slide, please. So we did, I've mentioned the report outs. This is something that we developed with our Leeds Improvement Method team around a target progress report. And this is literally for each clinical service unit. And they bring this to the report outs, but it also gives them a good guide as to how they're doing and areas that they need to focus on, and that given them the autonomy to focus on the bits that they would like to. Next slide, please. This is another example of how one of the clinical service areas actually collated their patient feedback and how they were doing. And they did those key words that people talked about and what they felt was important. So again, this has been developed, shared through the report outs, and then people have been able to replicate this within their own CSUs. Next slide, please. And again, this is just another example of a huddle. This was our respiratory department that decided that this is what they wanted their dashboard to look like. And this is what they've developed. And again, through that sharing in the report out style, it's meant that people have then contacted those other service units and said, this looks really good. Can you send me the template? And it's that scale up and spread has really helped. Next slide, please. Oh. Just there. So this is just a little snippet, and I'm appreciating I've really run out of time, of how we're measuring our impact. So one of the ways is around what's our number of internal delays, and that is probably higher than we'd like it to be. So what we have done is a focused piece of work within our operations centre to pick those up nice and early in the day and share those with colleagues so we can try and get on top of them rather than them tripping on to the next day. We've also got our discharge lounge usage. We've got our EDANs before 3, and we've also got our discharges before midday. Next slide, please. The ultimate one, which is what we all do concentrate on, is around our length of stay. And this is just a snapshot of December last year, where we did make an improvement in 3 areas. This is one of our focuses as an organisation, and our target is to reduce length of stay by 0.9 days. And we are working towards that. And this improvement programme has definitely helped us to do that. So just on to our last slide. This just shows some of what we classify as our target process measures. And the intervention bundle has been rolled out on 97% of wards, and that's embedded in, not just there and available. One of our big successes is that we've got 83% of our MDTs occurring before midday. We know that makes a difference to people going home that day and to flow of patients. and that we've got 88% of our patients being asked to respond to those 4 key questions, and therefore we can respond to what the answers are. The number of golden patients have been identified and are going to the discharge lounge before 10. And then we've got a plethora of EDAN data there, which is all going in the right direction. I think we have got some challenges around EDANs and getting medicines to patients, but it's certainly moving in the right direction. So sorry that was a little bit rushed, but thank you.
Alison, thank you so much. Again, just wealth of information and data. And I know that everyone on the call and through the comments have really appreciated this. And something that I specifically wanted to highlight was that I love the focus on being curious. I think that came out in quite a few of the presentations today. But I also really appreciated your kind of relentless focus on the patient involvement as well. I think that's absolutely critical, and really great to bring that to the fore. So thank you for that. I'll direct everyone again to the Google Doc for any questions and following up on answers. And appreciate we have run out of time, but I think it's testament to the brilliant presentations that we all wanted to keep going and kind of asking more questions. So certainly appetite for kind of follow-up discussions. If you are happy to kind of share your contact details, please do pop your email in the chat, and we'll think about how we can share that with the group who are happy to. And again, just a shameless plug for some other events coming up. So if you enjoyed today, then please do come along to the second of these sessions at the end of March. It's an hour-long session, and again, presentations with opportunity for Q&A. We've also got a great webinar in just over a week's time around prehabilitation and how that can help with some of this optimizing patient flow as well, particularly for surgical patients. So you'll see the QR codes there, and please do come along to those. They're both free events as part of NHS providers. And just finally, just a huge thanks to Michael, Paul, Alison and Tara for generously sharing the great work that they've been doing. We really couldn't have run this session without your fantastic input. And please do let us know what you thought of this session as well. Again, another QR code for you, or again in the chat if you prefer. Thank you all very much. Hope you have a great rest of your Wednesday, and do keep in touch. We'll speak to you soon and share the slides as well.